Thank you, Trung, and good morning, all. My name is Stuart Pomerantz. I am a clinical neuroradiologist at Mass General Hospital, a clinical IT software developer, and a project leader at our Clinical Data Science Center. And I am extremely pleased to use this opportunity to present to you our collaborative effort, Deep Spine, an AI-powered automated solution for diagnosis and reporting of lumbar spine stenosis MRI. So what are the challenges of lumbar spine imaging that we're targeting with Deep Spine? Well, lumbar stenosis is a highly prevalent cause of low back pain, disability, and particularly in the working age population. And it's a primary indication for spinal surgery. MRI is a study of choice for its evaluation, but it's time-consuming and challenging even for the most experienced subspecialty radiologists. Moreover, there's no consensus for the grading of spinal stenosis severity. And this results in suboptimal radiology reporting of spinal stenosis. We have wordy free text descriptions and a high degree of interreader variability. This confuses the referring physicians and their patients and makes decision-making for surgery and other treatments much more challenging. So we've utilized, over the past couple of years, the advances in technology that allowed for machine learning-based AI solutions, the computing infrastructure that we developed at the Clinical Data Science Center, and leveraged the years of clinical expertise encoded in our imaging and reporting archive to develop Deep Spine as an end-to-end processing pipeline ready for clinical deployment. Deep Spine has two components. It's a diagnostic and reporting solution. So let's focus on the diagnostic component. The algorithm generates level by level stenosis grading for both central and right and left foraminal stenosis, again, at each of the 6 typical levels of a lumbar spine MRI, through a range of severities, multi-class evaluations from mild, moderate, and severe, and normal. We've achieved state-of-the-art, world-class performance, recognized in publications and literature, with per-class accuracies in the over 90% range, which is superior to any of our competitors in the published literature. But it is also a reporting solution. So we had to develop, for clinical integration, an image-integrated interface for result review and validation for the radiologists to have confidence, and then populate the values into report templating solutions. And this is how we achieve some of those advantages where we have more efficient and accurate reporting with more standardized grading and report descriptors and reduced inter-observer variability. So let's look at how this works. So this is our clinical UI, and it's designed to allow the radiologist to scroll through the stack, and as they go through each level, the interface automatically updates the algorithm's stenosis grading in an intuitive and efficient way for the radiologist to validate the finding and then agree with it or change it. And then when they're ready, with one click, that data layer comes and it gets full text in the standard radiology format into our already deployed clinical reporting system. So now that we've achieved this end-to-end pipeline, we want to have, what are the next steps on our Deep Spine roadmap? Well, we want to leverage the data layer that's generated by Deep Spine to develop a portfolio of integrated solutions that we can partner with industry to target each of the pain points across the entire clinical workflow. So that will include image acquisition, workflow management, PACS integration, and reporting integration. So let me go through some of these. So to save time, MRI technologists usually acquire the imaging in just 2 stacks. This results in image slices that are not optimally angled to each disc level. This results in geometric distortions, which can lead to over or underestimation of the degree of stenosis. Deep Spine generates images that are oriented to each of the disc slices, obliquities. And as you can see, through our interface, as the user scrolls through, the green cross line angles appropriately to each of the spine levels. Deep Spine's data layer can also provide smart workflow routing through workflow management. Some spine studies are very easy. There's no disease or one-level disease, but some are much more complex and going to take a long time. We can route the studies to the environments that are more appropriate for this. A long study might not be appropriate for the ER. Might be better for a specialty trained radiologist in a quieter environment without interruptions. Again, deep spine's data layer predicts disease severity and the interpretation time. Finally, deep spine allows for multi-format reporting. So this is traditional text that's generated actually in a similar format to what radiologists are used to and referring clinicians are used to. Deep spine can generate. However, you can also use that same data layer to present the imaging in tabular, multicolored formatted, corresponding to the different degrees of stenosis. So at a glance, the clinician or the radiologist evaluating the prior study can evaluate and see where the worst degrees of stenosis are and where they need to focus on. We can use the saliency maps and information that comes out of our algorithms to actually generate the exact images that corresponded to those stenosis grades and use those to populate that tabular view as an image-enhanced view. So rather than just one or two key images, every key image can be populated. Again, the data layer can allow this. So once we've achieved this portfolio of applications all based on the deep spine data layer, let's take it to the next level. What are the aspirational goals for deep spine? Where are we going to need the help to achieve even bigger goals? Can we answer the big utilization questions of spinal stenosis imaging and clinical decision making? Who benefits from spinal imaging? Who should have an MRI? Who shouldn't have an MRI? Who should wait many more weeks or months to get that MRI? And can spinal imaging, once it is acquired, help us better avoid unnecessary spinal surgery or direct those who need it to get that spinal surgery earlier? So what will this require? We need to integrate that data layer that comes out of deep spine, integrate it with the big data that exists in EHRs, from commercial companies, in the VA system, military health systems, and even national health systems of other countries. So this is a big project, but we can then take the imaging information and combine it with non-imaging clinical data, such as the overall medical health of the patient, prior spine surgeries, their medication use, pain medication use, their occupational disability history, and where they are in pain scales, and use this to better predict who will benefit, again, who might need surgery, who might not need surgery, and so we can use then deep spine to assist referring physicians to make decisions far beyond the creation of a better radiology report. We'll provide big data for population-based predictive outcome modeling, and then tailor that to the individual patient for prognostication and surgical planning. This is a big project, and we need partners to do this. I want to acknowledge my collaborators in this, and I hope you all be as excited as they are, and myself, in what deep spine offers for us in the future. And I'm happy to answer questions outside. Thank you very much.